אוקיי, ההקלטה עובדת. הרב יהושע, אני עושה אותך הוסט. אולי כדאי לחכות עוד כמה דקות, כי שלחו עכשיו שוב את האישור. ואתה הוסט. אוקיי, הכל עובד, ההקלטה עובדת.
הרב ירון, אפשר לעשות את כולנו קו-הוסט? גם אותי וגם את דוקטור אדיר שאולוב בבקשה, וגם את הרב שרלו נראה. תודה.
עשיתי.
תודה.
אולי את הרב שרלו, לא, הרב יהושע, זה אצלך, אם תוכל לעשות אותו.
תודה.
הרב יהושע, במה שלך, אם אתה רוצה להתחיל, או בדקה, או לחכות עוד דקה.
A good evening to everyone. Based on the time in Israel, at least, we're already within twilight of the 3 weeks, which is a very loaded time historically. And I believe historically in the history of these webinars within the Ethical Center of Tzohar, I believe this is the most loaded topic that we ever dealt with. Not to mention the fact that for any family, this is the loaded topic that you have to make a decision on if it comes to it. If you can please mute yourselves, wherever you might be, we would like to begin. Based on the time in Israel, at least, we're already within twilight of the 3 weeks. And I believe historically in the history of these webinars within the Ethical Center of Tzohar, I believe this is the most loaded topic that we ever dealt with.
זה לא אצלנו.
Okay.
Somebody's broadcasting it twice.
Someone's listening to the YouTube, so you're hearing the delay.
So probably mute everyone.
Rav Yaron, if you can mute everyone, please, and we'll begin again.
זה אצלך הרב יהושע, או שתעשה אותי קורוסט
Okay.
בסדר.
הרב יהושע, you are on mute. You have to unmute yourself.
A good evening to everyone once again, and sorry for the technical difficulty we had earlier. My name is Rabbi Yoshua Grunstein. I serve as the North American Director at Tzohar, as well as a Rabbi of a shul in Efrat. Based on the time in Israel right now, we're already in twilight of the 3 weeks, which is a loaded time historically. But I believe historically for the Ethical Center of Tzohar, this is the most loaded topic that we ever dealt with. And I have to admit that from my years in the rabbinate, this is the most loaded topic that any family could be asked to make a decision on. From this perspective, I want to start right off from the beginning and say a disclaimer. And that is, you're going to hear a lot of information tonight, both halachic, ethical, medical, as well as other aspects. And I urge you in every which way to take in the information, but to remember that every single case is its own individual challenge. You cannot, from this webinar, start generalizing about what's happening in this family or that family. This is not a question like what happens if you forget to say Anenu tomorrow during the fast day. This is a question that has to take into consideration your family situation, your subjective reality, and therefore we feel an obligation to give you the information, but urge you all that when the time comes to consult with a rabbi, a social worker, someone you trust, and of course you have the 24-hour hotline of Tzohar to also consult with, in which we will get you on the phone with a rabbi proficient in these areas, as well as a social worker, and if need be, a lawyer. So without further ado, I'd like to turn over the stage to my dear friend, Dr. Adir Shaulov. He's not here because he's my dear friend. He's here because he is someone that, in his own right, is a doctor that deals with these issues on a day-to-day level. At Hadassah in Karim, he is a hematologist as well as someone that deals with palliative care, and he is an expert in this area. And we're going to start by asking him to give us the medical perspective as to what sedation is, when is it something that can be offered, and what does it mean for the family. Dr. Shaulov, the floor is yours.
Thank you so much, Rabbi Grunstein. So I would like to start off with kind of setting the stage first to what we're going to be talking about today. So palliative care, as most of you may well know, but I just want to make sure we're all on the same page, is an approach. It's an approach to care that improves quality of life of patients and their families. The focus is on quality of life, whereas most of medicine is focused on prolonging life. One does not necessarily have to come at the expense of the other, but the focus of palliative care is a focus on quality of life. And they deal with patients and their families who are facing problems associated with life-threatening illness. A big part of palliative care is relief of suffering through early identification, correct assessment, and treatment of pain, but many, many other symptoms. I just want to take a minute to talk about the use of opioids, which comes up quite a bit in palliative care, because till this day, opioids are still the most effective treatment we have for cancer pain, and in fact, for many other forms of pain at the end of life. We use it many times also to treat shortness of breath. Now, these are medications that have side effects just like any other medication. Early on, when you start treatment, many people have some nausea. Sometimes you can get a little bit sedated from this treatment. There's constipation, which does not improve over time, unlike other side effects. And a lot of us are worried or fearful of addiction, which has come up to the news in many ways, shape, or form, especially as we're within a very large opioid epidemic, especially in North America, with many, many opioid deaths, which are caused by deep sedation, followed by respiratory depression, caused by these medications when they're used in a form where they're not supposed to be used at. Now, addiction and deaths from opioids can be used by prescription drugs as well, but with professional support and guidance, this is very, very rare in the treatment of pain to see opioid deaths. And that usually may happen when you need to start treatment at very high doses and very early. However, for the most part, this is a very, very safe treatment, and it's also a very necessary treatment for people who are suffering from extreme pain, especially in the setting of cancer pain. But all this is not the discussion we're talking about today. Today, we're talking about palliative sedation, which is a completely different world, and I'd like to try to start off with what sedation is in general, because we use sedation quite a bit. We use sedation to depress consciousness of a patient, using sedative drugs with the purpose of alleviating suffering. And we use it when you undergo colonoscopy, which can be extremely uncomfortable. We use it in the care of burns. We use it in surgery. We use it many times even in gynecological examination. We use sedative drugs for the express purpose of alleviating suffering. For the most part, we use sedation as a short-term solution to suffering, right? Colonoscopy is going to be short-term. Burn care is going to be short-term. The surgery will be short-term. When we're talking about palliative sedation, we're talking about a sedation that is meant to alleviate suffering at the end of life, which usually means that the end of the sedation is going to be with the patient's death itself, and therefore it becomes very worrisome to many people with a fear that this may be actually hastening death, and we will try to speak that a little bit more later on. There are different forms of sedation. We can have continuous sedation or intermittent sedation. We have deep sedation, we have light sedation, and we usually use this as appropriate for the particular situation in which we're dealing. So I'd like to start off with just kind of clarifying what are the criteria in which we consider palliative sedation at all. First criteria is we're discussing patients whose prognosis is short, and we're typically talking about a prognosis of hours to days only. The second criteria is the primary goal of care of this particular patient is to avoid suffering. Usually we're in situations in which prolonging life is no longer an option at all. The patient is suffering and he wants to avoid their suffering in any way, shape, or form. Criteria number 3, and this is where things get kind of tricky, is that there is refractory suffering. And refractory suffering can be one of 3 situations. One is that palliative measures that we're using are insufficient to control suffering. For example, a patient is in extreme pain, and all the medications we've been using are unable to control that pain, whether we're using opioids or others. Second setting is when the palliative measures entail intolerable side effects. They may be helpful to alleviate the suffering. However, it's causing a different form of suffering, and therefore, this would be refractory to treatment. The third option is when we might find a situation where the palliative measures are not effective in a reasonable time frame. I may be able to control the suffering if I had enough time, but I need to leave this patient in insufferable pain or insufferable suffering for quite a bit of time until I'm able to get it under control. So these are the 3 criteria: prognosis, the goal of care is to avoid suffering, and the suffering is refractory. In many ways, we as doctors see palliative sedation as a situation when we have our backs against the wall. This is not something we choose because we have better options. If we had any better options, this would not be the choice that we're going for. I would like to take a few sentences from this important paper. It was written by the European Association for Palliative Care, and specifically Nathan Charney, whoever you know is heads palliative care in Czahar120 Medical Center. And it starts off with a very important sentence to me, and basically says that the EAPC, the European Association for Palliative Care, considers sedation to be an important and necessary therapy in the care of selected palliative care patients with otherwise refractory distress. However, as necessary it is, like any other practice, they may lead to harmful and unethical practices, which we will discuss a little bit later on, which may undermine the credibility and reputation of responsible clinicians and institutions. I think part of the importance of the meeting here today is to understand why this is an important treatment, how it is and can and should be done ethically and correctly by responsible clinicians and responsible families and patients as well. So when do we use palliative sedation? So this is a paper that looked at many other articles and reviewed them on indications for palliative sedation. As you can see, number 1 is delirium or confusion or agitation that we'd see at the end of life. The reason that this is number 1, because for many other symptoms, we have pretty good treatments. For pain, a lot of people are very worried that there's a lot of pain at the end of life. The fact of the matter is, in most cases, pain actually decreases towards the end of life. However, we do see a lot of confusion. The way we die is that the brain kind of shuts down slowly. Part of the brain shutting down is delirium. Delirium can have 2 forms. It can be over-agitation. It can also be over-sedation if people get too sleepy. When they're agitated, that can be very, very distressing. And the medications that we have and the treatments that we have to alleviate that suffering, in many cases, cause sedation in themselves. And this is the number 1 reason we need to use palliative sedation. Another common reason is shortness of breath or dyspnea, when again, the treatment options we have are not very good, and the feeling of suffocation, of having difficulty breathing, can be overwhelming for patients, and this is a primary indication we have for palliative sedation. But as you see, there are other reasons. We see less cause for sedation by using it for pain, but we do reach that need as well in some patients. Another area where there's a lot of controversy is using palliative sedation for what we call existential suffering. There's no specific symptom, there is no necessarily pain, there isn't necessarily shortness of breath, but this patient cannot bear life anymore. Now, this can be a significant form of distress for our patients. However, there are some problems with using existential suffering as an indication for palliative sedation. Despite the significant distress, moods tend to fluctuate. It's kind of hard to decide when this is really refractory suffering. Treatment for existential suffering or for depression or for anxiety does not necessarily have significant side effects, so there's not a lot to lose by trying other treatments. And what exactly is a reasonable time frame? Many people who suffer from existential suffering usually have a relatively longer prognosis, and you wonder if palliative sedation is really a good indication to use at this point in time. And even in this indication, we usually have options in which to try other treatments, or many times we would use a short-term sedation, try to see if this is something that we can kind of overcome over a reasonable time frame. Definitely not something that we rush into. Like any other treatment in medicine, palliative sedation has side effects. One of the major side effects is loss of ability to communicate. We would very much like to sedate a patient to the level where they're not suffering, but they're still able to communicate. But in many, many, many cases, or most cases, in order to alleviate suffering, the dose of medication that we will need will usually render the patient unable to communicate with their surroundings. And this is very important because if we're going to start palliative sedation, I will always make sure that the family has had time to say goodbye beforehand, and that the patient has had time to speak to whoever's important to them to speak to before we begin the sedation, because chances are that this is going to be the last chance. One of the major issues that we're concerned about is the possibility of hastening death. And here I want to show you a paper that came out of Israel, out of the hospice at Har-Tzofim, Hadassah Har-Tzofim, in which they retrospectively looked at all the patients who had died in an inpatient hospice over the current year. And they saw that out of 179 patients, 38 needed sedation. So we see this is quite common. About 20% of patients needed sedation in order to overcome their symptoms at the end of life. Here too, we see that over 70%, the indication for sedation was agitated delirium. The patient was not calm, he was pulling at things, he felt uncomfortable. Many times they suffer from hallucinations as well. The second indication was pain, and about 20% of patients, the indication was shortness of breath. As you see, 73 hours was the mean survival time since sedation began, which is quite a long period of time. An important finding in this study is the patients that received higher doses of palliative sedation actually lived longer, and we would expect that those giving higher doses, if we're worried about a risk of shortening their lives, they may actually live a shorter period of time. So at least in this study, we see no indication that palliative sedation shortens life. And it's not only in this study, in this review of multiple studies that were done on palliative sedation. You can see here on the left, sedated patients, and on the right, non-sedated patients. If we compare the mean survival time between these two groups, you can see the p-value, which is an indication of statistical significance, here on the right side. So none of these studies showed any significance between the two groups. In other words, they died within the same reasonable time frame, other than one study, here second from the bottom, where actually those who received sedation lived twice as long than those who didn't receive sedation, 6.6 days versus 3.3 days. So I can say safely that this treatment is relatively safe. We have no indication that it shortens life at all, at least not when it's used in a correct manner by experienced and trained clinicians. There may be risks with this treatment, and there are many risks with many of the treatments that we offer patients in general, not only in palliative sedation. And what allows us to do our job despite these risks is the principle of double effect, which is a principle in medical ethics. It tells us that for an action to be morally acceptable, we need to meet 4 criteria. I give chemotherapy to patients. It may end up really badly. It may end up curing our patient. But I aim to cure the patient. I aim to do well, not harm. But when there is a risk of harm, I need to meet 4 criteria. And criteria number 1 is that the nature of the act that I'm doing is morally good. For those who support euthanasia, euthanasia itself, or killing another human being, is not a morally good action within itself. Sedation, however, is a morally good action. Giving a patient chemotherapy or putting him under surgery in itself is not an immoral action. It may have a bad outcome, but it is not an immoral action within itself. Criteria number 2 is the means end. The good effect must not be achieved directly by the bad effect. Again, in euthanasia, in order to achieve relief of suffering, I must have the patient die. In sedation, I don't need the patient to die to receive the good effect. The good effect is achieved by the sedation itself. Again, when I give chemotherapy, the aim is not to cause harm, and I do not need to cause harm in order to cause good. Number 3, and this is very important, is intention. The bad effect may be foreseen and may be a side effect that is tolerated or may be even permitted, but the intention must be to achieve the good effect. And last but not least, proportionality. There needs to be a good reason to take this risk. In every medical procedure that we undertake, they all have risk, and we always ask ourselves, is there a good reason to take this risk or not? And in a patient with refractory suffering, there's a very, very good reason to take that risk. And this is clear within ethical literature. This is also within Israeli law. This is the Israeli Dying Patient Act from 2005, and free translation, that the responsible physician must do all that is in their power to relieve the pain and suffering of the dying patient, even if this entails a reasonable risk to the patient's life. This is my moral obligation, and this is my legal obligation. You can see this came out of the Ministry of Health in Israel, giving guidelines how palliative sedation should be performed, and this appears, I believe, in most countries around the world. So to summarize, and this is a very important point to me, is that palliative sedation does not equal euthanasia. And I know that in many countries around the world, euthanasia is becoming more and more popular. It's called medical assistance in dying, but palliative sedation is not in any way medical assistance in dying for a few reasons. First of all, intent of palliative sedation is to decrease suffering by decreasing consciousness. The tools we use are proportional use of sedative drugs that use just enough that necessary to relieve suffering, no more, no less. And the desired outcome is, of course, sedation in itself. Whereas with medical assistance in dying or in euthanasia, the intent is to decrease suffering by hastening death. By definition, the tools they use are sedative and paralytic drugs in a mix that's supposed to cause death, and the desired outcome in itself is death. I would like to try to disconnect these two as much as is humanly possible. So thank you all for listening. Thank you for your time, and thank you, Rabbi Gunstein.
Thank you, Dr. Sholov. I think everyone got a vivid description of what's involved in sedation on a medical point of view. And from this perspective, you understand that, like any medical procedure, there are, on the one hand, benefits and on the other hand, side effects. And from this perspective, the decision that has to be made has to take into consideration both sides of that particular coin. From this perspective, I think it's important to also point out that when you make this decision, it's not purely medical, but it has ramifications on the family, both at the time and, more importantly, after the decision is made. I can't begin to tell you how many families years later say, maybe we made the wrong decision, maybe we should have done this, maybe we should have done that. And therefore, this evening, we have the pleasure of hosting someone that has a lot of experience in this area, especially in the area of how a decision like this can impact the family and not just the patient. From this perspective, it gives me pleasure to welcome, I'm sorry, I'm going to catch my voice here. Thank you. Sorry about that. It gives me pleasure to introduce Debbie Bertlon. Debbie is the head of social work and social services at Czahar120, and she's going to share with us how this affects the family, how this affects the general feeling at such a situation. Debbie, the floor is yours.
Thank you. Can you put the מצגת on, please? Thank you.
With pleasure.
share with us. Okay, as he said, I'm a social worker in צהר120, as I'm working there, but my biggest job is I'm a social worker for caregivers in Ma'ale Adumim. Rabbi, can you just put it as I see it only on a little one, that everybody sees the slides big, or it's
I see it big.
okay, so it's only me. Fine. So we'll start. Dr. Shaulov spoke about what palliative sedation is. I just want to summarize it a little bit in order to go into the subject. And I will discuss it by the fact that, first of all, the medical team and the family wants the best thing for the patient. Nobody wants to do anything bad for the patient. We want them not to suffer. We want to be together and to do things that they're going to be happy about. No, this is not going to work. I have to control the matzeget.
No
And I
problem.
don't know how we do that, but I will
We'll
try.
take care of it in a minute. Continue talking.
Okay. So that's what we're going to try discussing today, how we work together, to let the patient be calm and and the family to be there for them doing the sedation. I think I will just share it, and I think it will be better. 1 second. Here it is.
Yeah.
I'm sharing it. I'm just trying to get to the beginning.
You also want to make it big on the bottom.
Okay, 1 second. That I know, but I wanted to get to the beginning. Okay, fine. So sorry for the technical problems. So we're going to continue. As I said, in palliative sedation, the family, the medical team, the family, and the patients are very important, and it's important for them to work together, and we're going to talk about it afterwards more. But what is sedation? Dr. Shulov said it, but I'm going to really go through it again. Sedation is the person is going to be blurry. He's not going to be with us, but for the family, he's still there, and he's going to be without suffering. Palliative, every palliative care is relieving of suffering. When you go into the hospice, the meaning to go into hospice is to relieve pain. They will not treat you, and no member family that you put into hospice, they're gonna treat to make them better. They're gonna make the person be comfortable, make the person be able to live comfortably until the end of life. So also with sedation, they put them to sleep a little bit in order for him to be calm. I will tell you 2 stories, and from that I will get to what I want to say. One story is Avi. Avi is 65 years old. He broke his leg. He broke his hip. He's with a lot of pain. He's coughing a lot because he has also pneumonia. And because he broke his hip, he's in bed. He's with diapers. From his emotion part, he doesn't want to live anymore. For him to live like this and to be paralyzed to bed and to be paralyzed, for him, he doesn't want to live. He wants to die. The other story is about Galia. She's 65 years old, the same age, but she is suffering from cancer that is all over her body. She's suffering with the cancer already for a few years. She did everything to try helping herself. The doctors did everything. And she's with a lot of pain and with a lot of uncomfortable. So she's asking to go out of the world. She says, I had it. I don't want anymore. And she understands what's going on. She knows. She asks to finish with the suffering. If we look at Avi, Avi is not a candidate for palliative sedation. He's not at the end of life. Nobody said that he's at the end of life. Yes, he has significant pain, but that's going to pass in a few weeks. And the doctors still have what to treat him with. But Galia, has a lot of pain. The doctors already told her that they don't have anything to do. And the doctors put her as a person that is going to die in a few weeks, hours, days, or weeks. So she will be a candidate for sedation, as Dr. Shaulov said beforehand. But how do we deal with it? How do we pay attention? How do we face it when you see somebody that is suffering so much? First of all, and that's something that I really want everybody to listen now, do yourself a favor. Talk about death. It's very frightening, I know. It's a subject that it's a taboo. We don't talk about death. Because maybe if we talk about death, it's going to come. I had a meeting with 2 rabbis. And one of them said that it's superstition to talk about death. The other one says to him, what are you talking about? It's better to talk about it and to be prepared than not to talk about it and people don't know what you want. It was a whole discussion between them. Halachically, it was very interesting. But in order to know what we want to do in sedation, we have to know what the patient wants. What did he say during his life? What was his wishes? Does he want DNR? Does he want to be tubed for food? Does he want to suffer? Does he want the doctors to do everything? Every breath that he's breathing in this world is important? Or he says, no, there's a point that I do not want to live anymore. And if we talk about it beforehand, it makes it easier for the family to accept and to have their position, what they think about what's going on. In Israel, there is a law there's ways in the law to write things down. There's what it's called Horaot Magdimot, that means general guidance that you give beforehand. You write it down. You can ask the doctors, the family doctors, they know about it. And it's accepted with Misrad HaBriut in order to know what the person wants. You write it when you have...
צריכה להעביר את הסליידים.
לא, אני באותו...
צריכה להעביר את המצגת, לא רואים את...
לא, אני באותו מקום, אני בסדר. And then people will know what was the patient's wishes. The doctors will want to know what the patient's wishes was. And that's important. Okay, we have to understand what the patient specifies, what his wishes was, and what the family thinks and what the family does. But this is hard when you do the sedation. The family sits there, sees the person next to him, he's there. Some people feel that it's a relief. He's not suffering anymore. The journey that we had as a caregivers, taking care of them, seeing him suffering, was very, very hard for them to see it. So it's a relief to see him that he's calm now. Other people can start even grieving and mourning and starting to prepare the shiva, to prepare what's going to be afterwards, and feel a little bit guilty because he's still here. But it's okay. It's fine. It's logical because you see the person and you know that in a few hours he's not going to be here because that's what God wants. It's not the sedation. Sedation just lets him calm down. And there's another thing that came up that Pauline Bose said, ambiguous loss. That means that it's a loss, but it's not exactly. We don't know exactly what's going on. It's a similar loss. Because physically, he's not here, he's absent. But sometimes, psychologically, I see that he's here. And I feel that I can talk to him. I can still be there. And sometimes people feel that psychologically, I know that he's not here, but his body is here. So what's going on? And that's what they call ambiguous loss, because you lose him a little bit. And sorry. And I really think that it's a gift. The waiting period that we have here, since he starts the sedation and you're sitting there, the waiting, you have to take it as a gift. That he's not suffering and you're next to him. But what can we do? So what is our job as a family? How can we cope with it? How can we, what can we do to help? What can we do to feel that we're part of it? So first of all, to get the atmosphere around, to be calm. Soft lights, speak softly. Be there. Be there for the person, actually standing there, actually being there. And connection. You can hold hands. You can hold his hand. You can pat. You can sing. You can give a kiss. Yes, you're allowed to cry too, because it's hard. Well, tears are allowed. Nobody says that you have to be brave in this situation. And it's a very good time to make close-up if you didn't get to do it beforehand. Dr. Sherwood spoke about the fact that before they started, they asked people to say goodbye. But sometimes you don't say everything that you wanted. So it's a time to talk, because everybody says that the last thing that goes in a man is the hearing before somebody dies. That's the last thing that goes. So talking, praying next to him, singing next to him. I will tell you a story about a family that came to me after the mother passed away. And I was with them a lot beforehand, so they came afterwards to tell me how it went and what happened. And they said that they were sitting around the mother's bed. She was not with them anymore, but she was still. The doctor still say that she was still alive. And the doctor said to them, "We have like a few hours, so talk to her, say whatever you want. She still hears you. Be next to her." It took a long time, and the doctors couldn't understand why she's not leaving the world. What happened here? And then one of the daughters came, the last daughter that wasn't there came in. She came in, she spoke to the mother. A few minutes after she spoke to the mother passed away. The mother needed her. She needed her there. Her soul needed to know that everybody is around her. But what the family told me, that was amazing for one side of them. That was shocking. On the other hand, the time that they were sitting there, talking to the mother, praying together, singing together, was very, very emotionally good for everybody. It gave an option of leaving the world, leaving the mother nicely and calmly. And about praying, I don't know, I hope maybe I'll have Cheryl will talk about it. There is a prayer in the website of צהר120 that can help in this situation. I really suggest people be next to the person when they do palliative sedation. Don't leave. Stay there. And Aaron Barak said something very nice about death, because the story that I said is one way. Other way is another story, that somebody can be next to next to the loved one for a long time, every day for hours. And then they're going to leave for a second, and that's the time when the soul will leave. Because some people prefer leaving when nobody's around, and nobody knows what's your loved one is going to want. And Aaron Barak said, that's how it is with death. It never surprises. We knew that she's going to die, but it comes as a surprise. Sometimes it comes as a surprise. Sometimes the soul decides to leave when everybody leaves the room. So don't say to yourself, oh, why did I leave my room? Why did I do it? I shouldn't have left. No, if you wouldn't have left, she would have suffered more hours until she would have left the world, because she wanted to leave when she was by herself. I just want to say for my end of my part is accommodating a loved one through their final moments while ensuring their comfort is a privilege for every one of us. And I really, really, really suggest everybody to do it. And I suggest you speak about death as you speak about birth. We decide that we don't decide that we come to the world. We don't decide when we die, but we can decide if we're going to suffer before we die. So talk to each other. Talk about your wishes, what you want to do, what you want people to do with you. What's your goal in life? What's your points that you want? What's your boundaries where suffering is the thing? And if you get to a point that one of your loved ones is in suffering and is in the end of life, be there. Be there for them. It's your privilege, not only his. Thank you.
Thank you, Debbie, for giving us a vivid description of what goes through the minds of a family and a patient under these situations. And after we got the medical perspective and also the family reality in such a situation, I'd like to ask Rav Sherlo to please share with us some of the halachic issues that go into making such a decision. There's no question we're dealing with the most cardinal issue in Judaism, literally pikuach nefesh, no other way to put it. And therefore, there are halachic issues involved. But the perception out there is one that almost on every webinar, afterwards, someone asks, well, I thought we have to always prolong life and do it under all circumstances, and that's what Judaism says, end of story. And I think this webinar, together with others, is here to tell you that it's not the end of the story, and that every situation is unique, and not always is the answer prolonged life. We heard this evening vivid descriptions of when life is coming to an end, and therefore I'm going to ask Rav Sherlo to please share with us some of the halachic considerations that go into making this decision. Bechavod Rav Sherlo, bevakasha. Rav? Okay, we see you. Just put yourself, you're on mute. Just unmute yourself, Rav Sherlo, and we're ready. On the bottom of your screen, there's two buttons. One says audio, one says video. The audio one is on mute.
Did you put him as a co-host? If he's not a co-host, he can't do it, because you unmute everybody.
Okay, Rav Yaron?
I did it. He's now co-host.
Okay, shalom everybody. And it's a kind of a nice feeling that you cannot talk, or you can talk to yourself, but nobody can hear you. So it's a nice experience that everyone can have. Like in many cases of halacha, the first thing that we have to do is to clear the ground, to clear the table. And I want, first of all, to dismiss two pre-assumptions, halachic pre-assumptions and two pre-assumptions, medical pre-assumptions. Some of them were mentioned before, and I only emphasize them. The first thing is that the halacha supports medical care, but there is no obligation and no commitment in halacha to extend life for nothing. Now, what's nothing is a great question.
Charlo, if I can just interrupt you a second. We're hearing you a little blurry. Wondering if you can perhaps put up the volume or take off whatever. Yeah.
Wait a second.
Oh, that sounded good. No, now we don't hear you at all.
Can you hear me better now?
Yes.
Okay, so I'll continue. So there are two pre-assumptions, halachic pre-assumptions that we must dismiss, and two medical pre-assumptions that we have to clear out and start the discussion after we know that there are a mistake. The first one, as I said before, there is no halacha commitment when someone suffers to expend his life. Actually, the halacha says that the doctors or the medical system had to get a permission, ורפא ירפא, מכאן שניתנה לרופאים רשות לרפא. So for healing, for bringing back a person to life or whatever, that's the permission that doctors received. But the medical system didn't receive even the permission to force someone to be connected to life, to suffer, and to expend his life constantly. So now, where is the line? Where do you draw the line? When do you pass the period of time that we must try to go to surgeries and to be healthy? And maybe the halacha even considers someone that decides that doesn't want as a kind of a suicide. And when do you cross the line? And the halacha doesn't force you to continue to expend your life. It's a good question, and we have to, as we said even in the beginning, Yeshua said it in the beginning, that it's every case is a different case, and you have to discuss it with the doctors, with the family, with the patient. But there is a line that from there's no even commitment or obligation to expend life. I'll say it even more, in a more extreme way. The halacha also demands empathy and compassion and understanding that suffering is something that we have to try as much as we can to reduce, and there's no, you cannot ignore the fact that someone else is suffering. The second thing is the approach or the attitude towards suffering. In some religion, suffering is even something that someone wishes that he'll suffer because it's making him more pure, or he will be rewarded by Ribono Shel Olam. We can find sources also in our tradition, but in most cases, our approach towards suffering should be lo hen velo scharan, not them and not the benefits that you get out of suffering. When pain comes, so when you try to work with it and you try to understand and what can you do with it and whatever, that's positive, because that is a kind of a reflection. But no one should say, and we should not say it about anyone else in our family, that the fact that he's suffering is actually good because all his sins are being washed and drained, and he'll come to the Olam Haba with a lot of zchuyot and everything. This is not the way to think. And in most the rabbis' literature, you see things that were written against this approach. So therefore, we want, from the halachic point of view, to reduce or even to try to that the suffering will disappear. Two pre-assumptions from the medical point of view that we have to dismiss is, as we said before, palliative care is not preparation towards death. It's not something that, you are desperate and because you don't see any future, you decided that let's get ready for death. Sometimes palliative care even extends life. Palliative care means that our decision is that from now on, our main mission is quality of life, not not healing. We understand it's the end, not other things, but quality of life. And as I said before, in many cases, palliative care is actually helping the person even to exist much more than without this palliative care. So we have to change our approach towards palliative care because, as I said, the main mission is trying to make the quality of life as better as possible. The second thing that we heard before, and it was medically and scientific way of exploring it, is that having a kind of a palliative Sdecya, whatever, or treats against pain doesn't shorten life. In most cases, it even may expand life, or at least it doesn't have any influence in it. So therefore, we have to understand that giving medicine or doing all kinds of this palliative care is something that is not shortening life. And as I said before, maybe it's even expanding life. So after saying that, what we should not think, let's talk about what we should think about the issue that we are dealing tonight. And I think there are 4 halachic principles that we have to put in our mind. The first one is something that you cannot measure, but in many cases, the Torah says, V'yareta me'elohecha ani Hashem. And our sages explain that there are the cases where no one can test it from the outside. No one can understand exactly or measure it. What is actually your motivation and what is your meaning when you are approaching this treatment of what we call in Hebrew Sdecya palliativi. But we should, first of all, understand that our motivation and our meaning and our target is to promote the quality of life and reduce pain. It's not shortening life. It's not something that, a bypass towards euthanasia. It's nothing like that, because if your motivation is, let's use the halacha in order to shorten life, and we'll say it's a kind of a palliative care, we'll say it's a kind of the Sdecya, but actually our meaning is to shorten life. This is impossible. It's something that you are not permitted to do. And the halacha, first of all, tells you, ask yourself, what is your real motivation and what is your goal, starting and figuring out what is the right thing to do. The second thing, as we heard before, the second principle, you're permitted to do that only when you are close to end of life. If someone is desperate, if someone suffers from all kinds of pain during his life, but it's not a threat on his life, it's not towards the end of life, you're not permitted to decide, I'll go to a kind of Sdecya, and then I will not do anything else, and I will not suffer, and who knows, even from 20, 30, 40 years. The halacha permits to use it only when you consider, when you analyze the situation, that you are close to the end of life. The third thing is the amount of doing that. And we understood from Dr. Shaulov that you can do it in a very high level, in a very low level. Depends what's the situation, what's the medical situation or whatever. But the halacha does, let's say, it forced the doctors to ask themselves, can you do and can you achieve the achievements that you want to do with this treatment with the less medicine that they can use? And why? Not because we don't want to waste medicine or whatever, but because we want to be sure that you are not doing something directly that will cause death. I said before that this kind of treatment, it's not the meaning, and in many cases even it's expense life, but it can be that if you are using a very high level, very aggressive treatment, then you are actually shortening life. So therefore the halacha and all the rabbis wrote that these are the main conditions. As I said, what is your motivation? What is the situation? What is the amount? And now I'm talking and I'm adding a fourth principle, that this is not a condition. This is a kind of a recommendation. And that is, we should not look on this case only as something that is, negative. We don't have any other solution, so let's do that. We should look that it's also a kind of an opportunity, a spiritual opportunity. Someone can farewell from his family, say goodbye, close all kinds of tension that he had during his life, being more, more relaxed, more finding the way to leave this world in a good notion, in a good relationship with his friends. In the Tanakh and also in Halacha, we see the importance of writing a will. I'm not talking about money. I'm not talking about inheriting. I'm talking about what do you want to say to your family? What do you want? How do you want to be remembered? Good recommendations and suggestions that you have for your kids, achieving peace in the family, and saying a lot of things so you can prepare yourself and use this situation in order to achieve a lot of achievements, as I said, with this procedure. So if I'm trying to summarize, I'm saying the following. First of all, we have to dismiss two pre-assumptions, two medical pre-assumptions through rabbinical or halachical pre-assumptions. And there are four conditions or four principles of doing that. This is the right thing to do when you get there. You should not use it before, but once you get to this point, it's the right thing to do. And it's better, as we heard from Debbie, that we'll give orders in advance to our family and to the staff, and there are all kinds of ways according to the law, that this is the thing that we want, and this is the way that we will want to leave the world. If chas v'shalom, we'll have a lot of pain and no future and nothing that can get out of this the period of time of declining. And this is the right thing to do, and we support it from the halacha point of view, from the ethical point of view, from the law point of view, most, and even I can say that mostly from the very humanity point of view, that people should not suffer when there is no need to suffer.
Thank you very, very much, Rav Sherlo, for sharing with us the halachic considerations that go into such a decision. I just want to echo what Rav Sherlo just said and add literally two things. Rav Sherlo just said that when you get to this situation, it's no longer trying to heal the patient. We're already past that, but rather, how do we make them comfortable? And what would be their wishes in such a situation? And I think once you're in that mindset, the decision becomes, I can't say totally easy, but easier than the mindset of, oh, he can still heal, he can still get out of this. As was written in the chat, once you put someone into palliative sedation, they usually or never wake up from it. And therefore, you have to put yourself in that mindset of, going ahead and getting them as comfortable as possible. I also want to echo one of the people that wrote on the chat. Her name is Rebecca. I don't know your last name, but she said that accompanying someone at those moments is one of the biggest honors you can give someone. And I think that what Debbie said is indeed true. And that is, you have the rare ability to say goodbye. You have the rare ability to be with someone at the very last moments here in this world, in Al Mahadain. And I don't want to belittle that for one moment. And just add that as a community rabbi, I'm asked many times, is it appropriate to bring up the issue of vidui? And I have to admit that vidui has a lot of heebie-jeebies and a lot of preconceptions with it. On the one hand, we say vidui almost every day. In davening, we say it definitely on Yom Kippur many times. And to say vidui in and of itself is a good thing that the Chazal said was a wonderful thing to encourage and to do, to confess for your sins. But on the other hand, it's no secret that it's very much associated with death. And therefore, to bring it up, you have to really make a decision if it's the right thing to do or not. And perhaps, and this is what I tell families, say vidui together with them. I can confess for my sins just like the person unfortunately on their deathbed. I also want to bring up that Debbie mentioned davening, and I think that's very important. However, when we're talking about palliative care, I don't think it's appropriate necessarily to stand there and say, may you have a refuah shalema. It's not only something that's a little ludicrous to say if we're talking about palliative care, klapei shmaya, in front of God, but also in front of the patient and the family. I personally adopt that we should daven to HaKadosh Baruch Hu for rachmei shamayim, for mercy from heaven. And God will make whatever decision God wants, but I think that's a more appropriate thing to say at that moment. And I'll just end before I ask Dr. Shaulov to continue, that even though we're in a situation of pikuach nefesh, and even though we're standing at that situation, it's not surprising that many people are still asking questions that have to do with the healthy patient. And I can tell you that a week ago, I was asked on a Friday about a patient that seems to be at the end of their life, and indeed that's what happened. And they asked me if they're allowed to give painkillers on Shabbat. Now, painkillers in a palliative situation, and Dr. Shaulov, you can correct me if I'm wrong, can also be an issue of pikuach nefesh. But on the issue they were asking was, is it a violation of Shabbos to take pills? And the halacha is very clear. When someone's in bed, sick, and beyond, as we're talking about this evening, of course you can take pills and medicine. But you should know that even in those situations, people are going to ask those questions that seem petty, but it's like an old friend. The halacha is there. It's like an old friend. And even when we're standing at the end, we ask those questions. So you should be prepared for it. I'd like to ask Dr. Shaulov to please make this even more tangible for us listeners, and maybe give us 2 cases that you dealt with, and let the other speakers see how they're going to deal with it. Dr. Shaulov, bevakasha.
Thanks again. I will present 2 cases very similar to the cases that we presented earlier. So the first is Reuven. He's a 45-year-old father of 3 with acute leukemia who's undergone multiple lines of treatment. He's now under relapse yet again. We have no effective treatments to offer. He's suffering from pain. He's confused. He's hallucinating. All this is uncontrolled despite our best efforts. And the patient and the team's priority is alleviation of suffering. The other patient, I will call him Shimon, is an 82-year-old man with a recent deterioration of his function, with no real clear medical disease that's causing this other than his age and perhaps colon cancer they had 5 years ago, which we really haven't followed up since. But he's deeply suffering from his loss of function and his loss of his independence. And again, the patient and the team's priority is alleviation of suffering. So going back to the criteria we discussed earlier, Reuven clearly answers the criteria for palliative sedation. He is suffering. Quality of life is the priority. His prognosis is short. And to do anything other than palliative sedation in his case would be to put our head in the sand. He needs our help, and we should give it to him. Shimon, on the other hand, is suffering. His suffering may not be physical, but he is clearly suffering. The priority for him is, of course, quality of life. However, his prognosis is unclear, and use of palliative sedation in this setting would not be recommended. There is a lot we can do to try to help him, and maybe at some point in time, palliative sedation will be a possibility. And maybe we can tell him, if you're concerned about suffering, if you're concerned that things will get worse, there are options that we can use, and in many cases, that in itself is alleviation of suffering. So I'd say for Reuven, I would look for solutions. I would consult with specialists, but don't bury your head in the sand. He needs our help. And if we have the tools in which to do that using palliative sedation, they should be used. Whereas Shimon, I would spend time looking for more solutions, consult with specialists, but at this point in time, palliative sedation is not appropriate. And I just wanted, 2 slides to talk about practical considerations when starting palliative sedation. So most of the work is before we start, and we need to make sure. We need to make sure we've tried everything that we can. We make sure that the patient is prepared, that the family is prepared. We need to make sure that the staff is prepared, that they're not confused as to what we're doing. And then sometimes the staff in itself want to say their goodbyes before it's too late. We usually start with very low doses, either intravenous or subcutaneous, and evaluate response because each person responds differently. So we give that low dose, we check to see the response. Sometimes we add again another dose. And only then do we calculate continuous dosing. Over time, we reevaluate, make sure the patient is comfortable, make sure that he's comfortable to a degree that's enough for him and is enough for his family. And a lot of times, the focus at that point switches immediately from the patient who is suffering so much until now, but is now relaxed, to the family who's waiting and waiting and waiting. And Debbie discussed how difficult that waiting period can be for the family who's watching their loved one drift away slowly. Just want to show what I'm looking for when the patient is undergoing sedation. You can see on the right, it's frowning. There's that creased brow. In the middle, a little bit more relaxed, but the crease is still there in the brow. And I always, tell the family, this is what I'm looking for. I want to see that he is relaxed. I want to see that brow completely relaxed, as we see here on the left. I don't need a monitor. I don't need to see the blood pressure. I don't need to see the heart rate. I don't need to see the saturation. I want to know that my patient is comfortable. And go back to this quote that no one really knows who said first, but the mission of medicine is to cure sometimes, to relieve often, and to comfort always. I think it's especially important when we're discussing palliative sedation. So again, thank you.
Thank you very much, Dr. Shaulov, for making that so vividly clear. I'd like to ask Debbie if she has anything to add to those 2 cases for the family.
I think we said everything about, and Dr. Shaulov said it, but I do want to finish this webinar and say I have something small to read. I will read it in Hebrew and then I will say it in English. אלי, תן בי את השלווה, לקבל את הדברים שאין ביכולתי לשנותם, ואת האומץ לשנות את אשר ביכולתי, ואת התבונה להבדיל בין שניהם. I'm going to read it just in English too, that everybody will understand. God, grant me with the sincerity to accept the things I cannot change, and courage to change the things I can, and wisdom to know the difference between them. I really think that we have to understand what's standing before us and to just accept what we can do and what we can't. Thank you.
Thank you very much, Debbie. Rav Sherlo, is there anything in these 2 cases that the family has to ask to halachically understand they're making the right decision?
I think that there is a combination, and the medical staff and the rabbinical staff, if I'll call it that way, should work together. and should work together because even if there are all kinds of principles of using this treatment, as Dr. Shaulov said, we have to understand that in many cases, when you come from two different notions and you really ask yourself, this is the time, because as I said before, everyone said tonight, there is a line somewhere where we cross it, this is the time, but it's not immediately. And did we try everything in it before we got to this position, and et cetera, et cetera. And then the mission of the rabbi is to do two things. One thing is to make the family relax and understand that they're really doing the right thing from the halachic point of view, from the ethical point of view, and etc. And as Debbie said, now we on our website wrote a few special tefillot for these situations. A tefillah for a family to make the right decisions. Before they make the decision, to pray to Ribono Shel Olam, to do the right decisions and to get help from the divine, and understanding that not everything that we do as human beings is in our hands. Many things are not in our hands, and we should get the wisdom and the courage and the ability and the passion and the compassion to do the right things, and to support this decision, because, as I said before, the family should know that this is the right thing to do when time and when the situation gets to this point, and not work according to, I think, wrong approaches and wrong idea that many people are thinking that this is the halacha approach, but actually, really the greatest rabbis, and on our website, in our presentation of Czahar120, we quote only the first line of the rabbis that said that there is no necessity to suffer and there is no necessity to expend life when times come to the fact that we should take care of quality of life, and that leaving this world will be in relax, in peace, and will be part of a process that all the family will be together with the patient without suffering, and knowing that he's going to a new world, to the Olam Haba.
Thank you very much, Rav Sherlo. And I'll just add to the words that were already said. I think this is a very unique opportunity when you get to this situation to actually say goodbye in dignity. We speak a lot in the Ethical Center about aging in dignity and many other things in dignity. This is literally to say goodbye in dignity and to say, I may ensure that my parent or my loved one was comfortable as they left this world. And thank God we have the technology and the medicine to do it. And therefore, I believe that when the medical ability to heal is no longer there, as that beautiful saying that Dr. Shaulov just showed, I can't repeat it because I'm not going to do justice. It was much better written than I'm going to say it. But when the medical world says we have nothing more to do, thank God we do have the ability to make a patient comfortable. And I believe that's our halachic and moral obligation towards our loved one. On that note, we're open to a few questions. There's a few on the chat, so I'll just repeat them. I believe I know the answer, but I'll just ask the experts. If someone's suffering from dementia and they're at this situation, who makes the decision for them? They, of course, cannot. They're not in the mindset. Who makes the decision? Now, here I want to be very precise. In Israel, it is different than outside of Israel. And outside of Israel, it's next to kin. But I don't believe that's the case in Israel.
So I'll maybe take this one. Outside of Israel, in many countries, there's what's called a substitute decision maker that's automatic. In other words, if not the patient, then their spouse. In Israel, there is no automatic substitute decision maker. However, unlike many other medical decisions, in Israel at least, and I think in most of the world, this is considered standard medical care. If you cannot alleviate someone's suffering in any other way, palliative sedation is standard of care. We always involve the family, despite the fact that they don't need to actually make a decision here. I don't need them to sign any forms. We involve them because this affects their life. And in many ways, once you start sedation, those who are suffering are the family themselves, and we want them all on board. As someone mentioned earlier, what happens when there's a lack of consent within the family. So I think that's where Tsara has done so much good in this field by bringing families together and having these discussions with them and allowing everyone to be heard, because I find it very, very rare occurrence that a family member wants their loved one to suffer. Everyone wants to do well. Everyone wants to do good. Sometimes they just need that help to understand together and to reach a decision together what is the right thing to do.
Thank you very much. Another question that came in privately has to do with the following situation. And that is that a loved one is at the situation that we described, but they did not actually prepare for their advance directives. If you can just give a word of how we can prevent that. In other words, how does someone healthy at 45, 50 say, when my time comes, this is what I want you to do?
So I can tell you the law in Israel, which is pretty straightforward. There are two ways in which you could make your advance directive. Either you fill out a form, there's an official form of the Ministry of Health. Any one of you who loves 9-page bureaucratic legal forms, this is going to be a hoot for you. Otherwise, you can appoint a substitute decision maker. And this you can do in complete health. However, this is applicable only when you are designated as at the end of life, that is a 6-month prognosis. So this is relatively straightforward. Yeah.
But I really
those
think,
forms,
but the forms, but that what Dr. Sherlock said are right and everything. And as he said, it's a very hard one to fill up. But I really suggest everybody, as I said beforehand, to speak to each other, because if the family, as a family, hears it everybody together, that's what he wants. So that's what he wants. And when they get to the part that Dr. Shaulov will tell them that he wants to do palliative sedation, they're going to say, okay, because they know that that's what he wanted. And it will be easier for them to say not to resuscitate, not to tube, or not everything, because as a family, as one group. And that's what the doctors want to hear. So just talk. Communication is something very, very important here.
So actually, I'll emphasize there are two notions. The first one is the legal, and Dr. Shaulov spoke about the law and the legal. But what Debbie said, there's lines, or between the lines of the legal and the legislations, the family, and when you talk the family, and when the staff actually realized that the family spoke about it and made a common decision, and everyone is on the same table, this is sometimes even better. I mean, I'm not talking, I don't want to, to shift people not to work according to the law, the legislations, and all those important papers, but talking about is very important.
I think also there's the Doroning ייפוי כוח מתמשך, another legal document. Also there's a place that you can write exactly what you want. So it's there too.
and as one of I think it was Aline Khan who wrote, you can be as descriptive as you would like on the ייפוי כוח מתמשך, on the enduring power of attorney. I can tell you that I filled one out a few years ago because of these webinars, and the lawyer never saw something so descriptive. But I said, I don't want the family to suffer. And therefore I put down even the rabbis that should paskin the shilas, so that, and if they're not alive, these people, so that the family does not have this onus on them. Which leads to a question that was just asked. If someone is suicidal and mentally does not want to live in this world, but obviously is healthy for all other states and purposes, Can this be an option? I believe the answer is no, but I want to refer the question to Rav Sherlow.
I didn't understand exactly the question.
The question is someone suicidal. He comes to the hospital. He doesn't want to live in this world. He's already attempted suicide, but his attempts were not successful. Are you allowed to
No.
help him with sedation?
I think no, and I think not according to the halacha, not according to the law, and not according to the medical ethics, because the first condition is, are there other solutions? Before you start with those, this is the last point. You don't start from the last point. First of all, you speak with a psychiatrist and they work on this function, and medically, and his family, and it depends, I mean, why did he commit suicide or tried to commit suicide or whatever? But this is not inappropriate. This is an inappropriate way to face problems in life, and we should be very strict with this idea because it's a slippery slope. Once you start using this sedation when it's not necessary and when you are not in end of life, before you tried all the other options and whatever, it's first of all a wrong thing to do, and the second thing is, as I said before, it's a slippery slope.
Absolutely. Another question that was asked, and here I'm going to refer to Dr. Shaulov, at this situation of palliative sedation, do you ensure that the patient is still getting fluids and not starving to death?
So the issue of feeding and what's called starvation at the end of life is a major issue, which I believe we addressed in previous webinars. I don't want to get into that entire issue. It is important to understand that at the end of life, appetite goes down. The ability to actually use nutrition given goes down drastically as well. So the question of palliative sedation is completely disconnected from decisions about feeding and fluids. By law in Israel, fluids must be continued unless they cause any form of harm, of course. And feeding in the last 2 weeks of life, at least, is definitely not necessary. And in most cases, giving feeding in any way, shape, or form along with sedation causes more harm than good. So fluids, unless it's causing damage, we usually continue. But discussion about continuation of feeding in any particular form there is usually a discussion that we have with the family before we even start with sedation.
Okay, thank you very much. And just one last question I was asked privately, which I think is important. When the family makes the decision, when they decide we're going for palliative sedation, what do you do as a doctor? And should the family be in the room? Meaning, is it just something you put into the intravenous? Is it or should you say to the family, please leave the room for a few moments, just as advice for the family?
Yeah. My approach is actually the exact opposite. First of all, before we start sedation, we call everyone in, right? Everyone who wants to say goodbye, this is the time to do it. It's a very valuable time, as Debbie discussed earlier. I keep on repeating this, but it's important to say again, death is not a medical event. It's a social event. It's a religious event. It's a private event. It's a personal event. It's not a medical event. We happen to be there. We happen to be a major part of it, but it's not a medical event. I think most people, I prefer to have the patient in the room to see what we're doing and why we're doing it. What am I looking at? Right? Let's look at him together. Is he suffering now? You know him better than I do. Does he look like he's not doing well? He seems more relaxed right now? You give that first dose, we see together, we decide, is this good enough? Is this not good enough? Is this, what you were hoping for? Or do we need to give him a little bit more? Usually you need to kind of walk through that together for everyone to feel, comfortable with the fact that the patient is comfortable and that we're comfortable with what we're doing. So usually we would start off with that together. And I personally make a point of coming in as often as possible afterwards, because there's this feeling that, once we start sedation, no one's going to come in the room anymore because there's nothing else to do. But no, there's a lot to do. I want to make sure that he's comfortable. I want to make sure I found the right dose. I want to make sure the family's doing okay. So I would make a point of being in there as often as possible.
Okay. And I said it last question, but I see a follow-up. what medication exactly is given to start the sedation? Is it something that's given orally? Is it given in intravenous?
So in general, oral is not an option at this point. The patient will not be able to swallow it. So it's either intravenous or subcutaneous. You can give it under the skin, even in a continuous manner. You can do that at home without needing to prick and find a vein. So that's very convenient. Someone asked about what medications are used. So we're obviously not giving any instructions on what medications are used, but we're using medications that are used for sedation. This is not where we use morphine. Morphine is not a sedative drug. It's a pain drug. We use medications that are used for sedation. This is mostly, for those who are more familiar with these medications, benzodiazepines or diazepam, midazolam, mostly. Those would be the most common, but there's a variety of medications depending on the situation. If the patient is more agitated, you might use different medications. The idea would be to be something that I can control the dose, find the right dose, and not cause any harm, of course.
Okay. So as we end, I want to thank everyone for being with us on this very loaded topic. And I just want to ask each of our speakers if they can maybe give a final tip to people. I hope no one has to be in this situation, but it seems to be part of life at a certain point of life. So if you can give a final tip, Rav Sherlow, Debbie, and then Dr. Sholov.
My final tip is the way that I try to present the idea of, first of all, cleaning the wrong thoughts about Allah and about medical treatment, and understanding that we should be in work according to a combination and a cooperation, I will say, between halacha, ethics, medical care, and the law. In Israel, they're partners, they're not enemies. And when you work according to this idea, you understand that the most important thing is that we should do everything that we can, that people will not suffer.
Thank you very much, Rav Sherlow. Indeed, I think looking at everyone as partners is very important in those final hours of your loved one here on earth. Debbie.
What I will say, I said it a few times, but I will say it again. Emotions, say your emotions, talk about your emotions. Don't leave anything behind. When somebody, your loved one, is next to you on the end of life, tell them everything that you want to tell, because afterwards you're going to regret it. Be there for them. Nothing is more important than being with your loved ones at the last hours of his life. Thank you.
Thank you very much, Debbie. Dr. Sholov.
So two short points. First of all, I feel always that when we talk about palliative sedation, we talk about the final hours of life, get the kind of perspective that this is what palliative care does. So it's a major part of what we do, but palliative care starts way, way beforehand. Even when there is extended prognosis, even when there's a chance of cure, there are needs, there are symptoms, there's help that patients need, and it would make sense to call in palliative care early. Second would be that you shouldn't go through this alone. This is a very difficult decision. It's a difficult place to be in. And I think in every place in Israel, you can get access to palliative care. Tzahar120 is an incredibly useful tool that I would encourage you to use. Try not to deal with everything on your own.
Thank you very, very much. And thank you to all our speakers. I'll just add, Bishulei Gli Mehem, that at the end of the day, when you make that decision, I'm going to repeat something that I once heard at a wedding that I was very astounded that was said, but I think it's very appropriate in this situation. We were sitting at a table, and someone that's an anthropologist, who thinks like an anthropologist, said, this couple couldn't have done any better. And we all looked at him and said, that's so inappropriate. Why would you say that? What do you mean they couldn't have done any better? But I think that Dafka in this situation, it is the most appropriate thing to say to a family when they make the decision, especially when they make a decision of palliative sedation, to say you couldn't have done any better for your loved one. There's no perfection in the world. Perfection is a word that exists in the dictionary alone, not in real life. We have to do our utmost best, halachically, ethically, and medically. And once we do, I think it's important to encourage the family. You did your utmost. You did your best. And that's exactly what your loved one would have wanted from you, and you didn't. On that note, wishing everyone all the very best of Besorah Tovot for you and your families. Be'ezrat Hashem, we should see this very day turn into a yontif, and Be'ezrat Hashem, you should have many more years of health and happiness with your families and make the best possible decisions for them and for their welfare. Thank you all very much for joining us. And for the last question that was asked, yes, this is recorded, and we will put it up on YouTube once it's ready. Thank you all very much.